Today is really covering a lot of information that you're not going to see in the adult med-surg. They're really specific to children. I am going to try to get a PowerPoint and a Kahoot with 50 some odd questions done before 5:30. And I'm going to run as fast as I can to get you that information, okay? But it's really, you'll see as we go along, it is a lot of stuff to look at. So let's go right ahead. Anybody have any questions before we start? Okay. Remember, anyone who has a question, do not hesitate. Come on, ask me the question and I'll answer it as best as I can. So if you have a question, somebody else probably has a question too. Okay. The first thing I just wanted to talk about was that pediatric assessment assignment. Okay. It's now week 8. We're doing GI and GU. That pediatric assessment assignment is due by Sunday. You still have diabetes also due and the pediatric assignment exam. A lot of stuff due. Remember, stuff you don't get done this week, you have one more week minus 10%. So just in case you have to do something like that, pick and choose what you're going to minus 10% on. That pediatric assessment assignment, as I said, choose something that's near and dear that you'll learn something from. It is a 250 word, just describe me your diagnosis in APA format. And you should have 2 references. You can use your book and somewhere else, okay? On the assessment, fill it out as completely as you can on the diagnosis that you have chosen. So the child that you're assessing virtually, most of you, that assessment matches what your diagnosis was. For instance, if it's asthma, those lungs better be with expiratory wheezing, okay? And coughing and retracting and all of those things, okay? For instance. Now, the teaching tool, teach me something about that. Could it be how to give myself, do a peak flow every day? Could it be a G-tube feed? Could it be how to organize myself for ADD? I mean, there's so many things it could be, or the follow-ups that needed, what therapies that are needed. So if it's a PowerPoint, 4 or 5 slides. I don't need a lot of crazy stuff. Or the brochure, which a lot of you are choosing brochure, but just make sure on that PowerPoint or that brochure, you do attach 2 references, okay?
Professor,
Yes.
so I can send a PowerPoint instead of the AP paper, or have to be both?
You do 3 sections, a paper, the assessment form, and the teaching tool, which could be a PowerPoint. It's 3 parts. Now, my students, you turn it in early, I'll review it, send it back, and tell you how you can improve your grade. And I know that the other professors are doing the same. So we want to teach you APA, getting you ready for those future degrees, okay? Because I know many of you are going to go on. And the BSN is all papers, all papers. Get to MSN, all papers, all papers. Go to PhD, oh, more papers. So learning how to start to understand it now is getting you ready for those future, okay? So I use this as a learning tool. There's no right or wrong. Send it in. I'll tell you what's wrong. You have the right to correct it or not. That's your choice, okay? So let's go ahead. Any questions, anyone from any class can email me, okay? I will answer. Remember, I'm over everybody. So if you have a question, your professor can't answer it, or you want to hear it from me, please just send me a message, and you know that you have also my cell phone also. Okay, here we go. GIGU is a lot of information. GU. Well, GU, when we think about children, we think about urinary tract infections. Biggest thing you'll ever see, most common of all conditions of infection in children. And we know that we'll see it in little girls because of these little short urethras and because of the potty training, wiping the wrong way, etc. Also, in uncircumcised boys, many parents don't want to pull down the foreskin and clean that schmegma out. And that schmegma is like a petri dish, and it just builds up bacteria, which goes into the urethra, into the bladder, and infection. So one of the things with any antibiotic, make sure they finish it all, okay? Some parents say, well, oh, the kid's better. They don't need all the antibiotics. Well, we know how that can happen with strep, right? We don't finish it all. Other things can happen. And you don't want to mess around with a child's kidneys at all. So how do you know they have a urinary tract infection? Well, the incontinent, when they're already potty trained, that urine smells foul, or that frequency, urgency. It could even be they're incontinent at night, enuresis, where they have been a dry bed for a long time, okay? So we need to teach them about simple things. We need to teach them to clean the proper way. Little girls, bubble baths don't really mix if they're into urinary tract infections because that dirty bath water can go up into that little short urethra and cause infections. And then the adolescents. I mean, we know we're supposed to say that, yeah, you should be abstinent, but we know adolescents are going to do what they want. So if they're having frequent urinary tract infections, one of the things we can tell them is to urinate as soon as they can after intercourse, and that does decrease incidence of urinary tract infections. So what do we do for urinary tract? Well, we're going to do a urine for culture and sensitivity. On infants, smaller children, we don't bag urines for a urine infection because we might just get skin contaminant. And we're not going to want to do 2 or 3 antibiotics on an infant or a younger child because we could really go into polynephritis and hurt kidneys. So we do a urinary cath. It is quick. It's uncomfortable. I've had a catheterization. I know what it feels like. It's uncomfortable, but that little pacifier, right? Mommy holding, talking to the baby, boom, boom, in and out, and you've got a great culturing sensitivity. Now, what about those itsy bitsy premature babies? And if you're going to work in the newborn ICU, there's no catheter small enough. So what we do is a suprapubic aspiration. Right above the suprapubic bone, they clean it, they go down with a needle, and they'll aspirate. Could be a half a ml of urine, but it is a sterile procedure. And of course, we're going to make sure they had something for pain. There's all of those things that we can do. Ultrasounds of the kidneys, looking for, some sort of the structures is not the way that it should be. If they're older, getting into 2-3 years old, and there's still problems, they do these voiding cystourethropographies, again, looking to see if there's reflux going on. And then there's IVPs for older kids in the scans. Now, sometimes we get to the point where we have these kidneys with these infections and we can't figure it out, and they are chronic. So we might have to do a renal biopsy. Well, a renal biopsy and a cardiac cath, sort of the post procedures are very similar, as in bed rest for 24 hours, right? Just think about, we put a needle into the back because your kidneys are in your back, in through your back into the kidneys. So it could bleed or it could leak urine, okay? Because that's a hole you punctured into the kidneys. So bed rest for 24 hours and a pressure dressing or a sandbag, just like a cardiac cath, right? And we're going to be monitoring that dressing for any oozing, and because it could be leaking into the abdomen, urine or blood, we're going to look for tenderness, we're going to look for pain, and of course, monitoring intake and output because we've just punctured that kidney, okay? Most of these children are put up into some sort of anesthesia for this procedure because they have to hold quite still. Now, one of the things we find out with urinary tract infections is obstructive uropathy. That means there's a kink in the hose somewhere. It could be, now they call the bladder a vesicle. Okay, it's a vesicle that holds something. And it could be up one of the urethras, ureters. Could be one, could be both. And the thing is, if we can correct them quick and allow the urine to flow correctly, we know that we're going to be preventing these sort of infections. And that's a picture just like your book to look at it. Just know that there's a vesicle and there's the ureters and the kidneys. And the one thing we worried about kidneys is that it can't get the urine down, so we go to hydronephrosis, which could damage and kill your kidney. Now, One of the things that children can get is something called nephrotic syndrome. Now, let me tell you something. It has nothing to do with renal failure. Again, this is not renal failure. This is the kidney's inability to hold on to protein. It says, protein, I don't like you, and it just spits it out. So what do you see when you don't see any protein in your body? Well, you're going to see it in the urine because it keeps getting rid of it. Now, isn't protein in your blood? Doesn't that have to do with the way medications, drugs are handled in your body? If you don't have protein, you have a lot of free drug in your system. So you're going to need smaller doses to do the same thing. It also causes a lot of fluid to go interstitially. So this child is going to be full of liquids, swelling, edema, even the mouth, the tongue. That's why they're not going to eat well. And these children are gaining weight because of lack of protein. So what do you see and how are we going to treat this? Well, any person with any fluid holding, we're going to be doing that salt restriction, fluid restriction, and we'll be monitoring how we're doing by strict intake output. And we're going to be doing daily weights. Anything with fluid management, strict INOs, and daily weights, okay? These children are immunosuppressed, so risk for infection because of all that swelling in the mouth. They keep biting on their tongue and their cheeks. They have their appetite goes way down. And this is not something that goes away. This is a lifelong chronic condition. So you do need family support and they do need to be closely monitored. So again, what is our goal? Well, we want to try to reduce the amount of protein that's sent out. And we do give corticosteroids to this patient. That's the treatment for this. Try to prevent infections because number one, they're immunosuppressed and we're giving corticosteroids. So that also decreases increases your chances for infection. So also, again, nursing priority, strict INO, daily weights. Remember, anything with a fluid balance. Now, here's the other thing that has to do with strep. Acute glomerulonephritis, your kidneys stop working. They hold on to the fluids, they don't excrete it, and you'll see them. No urine output, blood pressures go up, or you're going to see really foamy, bloody sort of urine. One of the questions that we'll be asking is, has your child been sick lately? And usually it's a strep infection that either they had a sore throat that they just went away, or they didn't finish all of their antibiotics. So these are the things that you're going to see. Again, this is a fluid balance problem. You're oliguric, you're not urinating. So you're swollen. With that swelling cause hypertension. You have the hematuria and the protein is also going to be thrown out in the urine. Now, what's the prognosis? Well, we need to treat the strep infection, right? So we will be treating them with antibiotics. And usually we can cure them. So it's an acute stage. And this is something that's curable as long as we get it quick enough. Now, some of them, because they weren't treated quick enough or they're non-compliance, they become chronic, which means they'll always have problems with their urine, oliguria, and requiring those fluid restrictions and salt restrictions and being monitored closely. So again, watch this fluid. It's going to be daily weights, INO. And in this case, with glomerulonephritis, we'll be measuring the abdominal girth. Maybe there's some urine swelling going on in the abdomen. Again, low sodium, fluid restrictions, and also some susceptibility to infections.
Hey, Professor,
Yes.
I have a question. What causes this? What causes the glomerular?
Glomerulonephritis is due to a strep infection, sometimes even viral infection that wasn't treated and it attacks the kidneys. So in order to cure it, you've got to treat the cause, which in case of the strep, you're going to be giving those antibiotics. Okay? Wilms tumor, very interesting tumor. I've seen one in my lifetime. It's a kidney tumor, and it's in African-American children, more frequently in boys, and they're right around 3 years old. I had a child from Haiti during the earthquake back in 28, 10, somewhere, something like that. And he was found by our hospital staff. And through some sort of religious agency, we got him over to this country. And some women picked him up from one of these agencies and dropped him off in the ER. All of his papers were in French, so I couldn't read them. So I had to do an assessment. So, of course, as much as possible, got on the level of this little boy. I was able to do a complete assessment. And when I was feeling his abdomen on the left lower quadrant, I felt a softball sized tumor. And for some reason, I knew it was a Wilms tumor. Now, one of the things about this tumor is that it's a solid mass, but with manipulation, little microembolus or metastasis can occur. So do not palpate that abdomen as soon as you know better. This tumor, we don't even do a biopsy. We are not going to impregnate that with a needle because, again, it'll spread the tumor around. So how do we treat this? Well, pre-op, leave the belly alone, maybe do chemo or radiation or both. And then we do a big surgical removal of it. And it goes right down through the belly all the way to the back because that's where your kidneys are. So there's a lot of issues on the urine after surgery and also monitoring the bowel because of the manipulation. Sometimes they have some bowel obstructions. Now, renal failure is either acute or it could be chronic. Acute is usually due to some sort of disease, could be chronic urinary tract infections, or it could be one of those reflux or an obstruction that's going on. And chronic is usually they're having long-standing disease or it's congenital. Now, one of the things about acute renal failure, we know that it causes a lot of things. Same thing with children as with adults. But one of the causes that is not, you don't see in adults is severe dehydration can cause acute renal failure. That's why one of the things we're going to talk about is how to rehydrate your child in case of too much vomiting, too much diarrhea, because dehydration can be very serious. Now, chronic renal failure is when more than 50% of the kidney is not workable. And it's just a progressive deterioration. They call that uremia. Causes of chronic, well, again, could be those malformations, could be that reflux, hereditary, could be passed down generation to generation, and then those chronic type of infections, and then anaphylaxis purpura or lupus. Lupus attacks all organs, right? Can attack your kidneys also. So what do we do with our management of it? Well, chronic renal failure, usually on the older children, is going to be dialysis 3-4 days a week. We're going to be trying to maintain as much renal function as we can. It's always worried about fluid, electrolytes, intake, outputs, daily weights, all those things, very important. And the other thing, just like in adults, their hemoglobin hematocrits are going to be low. So we will be giving them also the erythropoietin, which is a subcutaneous injection, daily, weekly, whatever the physician wants. And with kids, and even though it's hard, we try to let them be kids, try to be as active as they can in between all of their treatments. Now, another thing we can do in dialysis is on the infants. Now, you're going to say, well, why don't we do hemodialysis on a small baby versus doing a peritoneal dialysis? Well, the flowing of blood is so much flow that it can rupture the vessels in the brain on a newborn infant. And usually they have to be 3, 4, 5 years old before they'll go to hemodialysis. Now, peritoneal dialysis is pretty neat, and it leaves the child at home. And parents are instructed on how to set this up. I've seen one parent with a child who had what we call prune gut, who had kidney failure, who had to have peritoneal dialysis from birth. That child was the cleanest baby. The dressings on the abdomen were as good as I could have put. And this child maintained that until they went and got their kidney. transplant, and he is now doing very, very well. So peritoneal dialysis, what is it? Well, do you see that tube? It just goes into the abdomen, and your abdomen becomes the kidney. And what happens is we take some sort of solution called diastolate, and it's on a warmer on a machine, and we warm it. You're not putting cold stuff in the belly. And then we put a certain quantity and put it into the belly, and we let it sit there. It's called a still. And once it sits there for 20 minutes, 30 minutes, we allow it to drain, and it goes into a Foley catheter. And the difference between what the fill is and the drain is the urinary output. Now, one cycle is a still and a drain. Most infants at night will do 8 to 10 fills and drains, okay? So it's all night long. It's got long tubings. The child can move around and it works well. Now, what are things we need to look out for? Well, abdominal tenderness, redness. But if we start seeing that drainage change colors, or you see a lot of like, sediment in there, that is a risk for infection. The healthcare provider must be called immediately, because according that healthcare provider is probably going to want to do some sort of cultures and put that child on antibiotics. So the biggest risk is infection. Now, that's their only kidney. We have to protect it. So what best describes acute glomerulonephritis? Come on, Jose, you know that answer.
B.
B.
Yep, it occurs after that streptococcal infection. That is usually the cause. Thank you. Okay, GI. Going to get into a bunch of other stuff, okay? Well, first of all, GI is mouth to anus and all the absorption that goes in between, right? So there's a lot of things that are involved with it. We absorb all of our minerals and vitamins and everything that we need through our GI system, right? We know that if we don't get the proper nutrition, we know infants, cognitively, they're not going to be there. They're fine. The gross motors aren't going to be there, and they're not going to grow. There's other stuff that can cause it: cancer, HIV, sickle cell, cystic fibrosis, and low birth weight. But nutrition is very important. Celiac disease is something that has to do with gluten. Now, in the small intestines is where a lot of the absorption of your foods occur. And if we let gluten food go in there, it gets all irritated and it doesn't absorb food. And what we will see is what we call steatorrhea. It does not absorb fat. Now, not only does it not absorb fat vitamins are not absorbed also. So we must replace those also. Now, these steatorrheas on gluten, celiac disease children or adults, it stinks to high heaven. I mean, it's called malodorous, but it's beyond malodorous, and it could be even foamy that you might see. So they're not getting fat. And if we know anything about nutrition, fat's 9 calories per gram, right? And we have carbohydrates and proteins at 4. So your biggest supplier of calories is gone. It's not absorbed. It can't be used. So how do we treat it? Well, we put them on a gluten-free diet. So we're not going to be given these brands. We're going to not give oats and wheat and barley. There's 4 different things we don't do. And we're going to put them on things like they can eat all the fruits and vegetables they want. They can have chicken, salmon, tuna, beef, any of the types of dairy, yogurts, milk, nuts, seeds, herbs, spices. It's basically like cakes and cookies and breads. You know, these children today are so lucky because the local supermarkets have gluten-free written everywhere, don't they? Can you imagine 20 years ago, they didn't have that. Food allergies are common. That's why we start very slow with our newborns at 6 months. We'll just introduce one food at a time, right? It could be as simple as lactose intolerance, which your kid will be gassy and lots of diarrhea. Or it could be, you see rashes. And usually the rashes are under the neck and in the bends of the arms and legs, those hot spots, right? And we'll see even diaper rashes. We'll see them. If we start seeing them, we can suspect that that's probably a food allergy. So it can be a concern. Now, GI function could be many things. Well, number one, kids always they're spitting up calories, especially the young children, right? So it could have growth failure. It could be nausea, vomiting, diarrhea, constipation, abdominal pain, all of these things. It also could be caused by dysphagia. Now, there's one syndrome called DeGeorge syndrome, and they have little tiny little jaws and they can't chew and eat and swallow. So it could be because they have that, they can't coordinate to do it. So dysfunctional swallowing. And we know fever burns fluid like crazy, and children don't eat when they have a fever. Now, dehydration, of course, is when the out is more than the in. And it could be due to many things. It could be due to fevers, biggest thing that you'll see. All of a sudden your kidneys are excreting a lot. Or maybe you had some foods, like teas that will increase diuresis. Could be vomiting, diarrhea, ketoacidosis, and of course burns could cause it. Now, in dehydration, what do you see? Well, the infants are the easiest one to tell because you can look at them. I mean, look at the color of that child up top. Do you see he's pale, white, sickly looking? Well, that child right there has a fontanelle at rest, sitting up, that he is sunken. Now, they should be flat. Now, there's something wrong with that. Then you look at the ears, they're pale, the nose. Next thing, what am I going to check? I'm going to check a heart rate. Is it higher than normal? I'm going to check a blood pressure. It's going to be lower than normal. I'm going to check capillary refill. It's going to be prolonged. Could be 5 or 6 seconds. Urine output could be non-existing. And I think the saddest thing is a little infant crying and having no tears. And when you see no tears, you're in big trouble. So what do we do for dehydration? Well, number one, it depends on why it's there. And if it's vomiting, if it's diarrhea, if it's both. If a child is vomiting and cannot take oral, we're going to be starting an IV. And as we start that IV, it's important to get a basic metabolic profile, your electrolytes. Where is my potassium, right? Where is my sodium, my chloride? I want to know what I'm starting at. Very important electrolytes. Then we're going to give fluid replacement. Always remember, if we're bolusing fluids, it is never, ever, ever, ever with dextrose or any potassium. It must be normal saline, Ringer's lactate even can be given. And these children, unless we have a potassium on our electrolytes, no potassium can be added to an IV until they urinate. We're protecting kidneys here, okay? Also, if they're vomiting, of course, we're going to give an antiemetic to try to stop it. Now, how do we accurately measure intake and output? Well, we're going to measure anything that comes out of the child. I mean, if a child is really severe, we can even measuring sweating by putting like a chucks underneath, weigh it before we put it under, take it out, see how much it weighs. There's many things. We usually don't go that ridiculous, but the vomiting, usually we're guesstimating how much, but urine, stools. But I think the biggest thing is looking at those vital signs. Is the heart rate slowly going up? Is the blood pressure slowly coming down? Is the urine output decreasing? All of those things. And we're looking, of course, anything with fluid is I and O and daily weights. How many times can I say that, right? Anything that deals with fluid is your priority. Intake, output, daily weights. And in infants, it's great. We can see it right on top of their heads, right? And older children will get confused. We'll see all of the other signs, but they're going to get not as alert as they should be. Now, there's all types of diarrhea, but the thing is, they're losing something in diarrhea. We know that diarrhea has a lot of alkaline substance from the digestion of they digest food in their lower GI tract, right? So this child can go into metabolic acidosis because of loss of all that alkaline. I tell you these things because the HESI loves acid-based questions. I think the last one that I knew of, there was 4 of them. So this is why I keep reminding you of them. Now, the kid is diarrhea. and is able to drink, we will go directly to oral rehydration, which could be a Pedialyte, Gatorade, Powerade, one of those. Get the fluids in slowly. If they are unable to drink, or if they're vomiting with it, then we go to IV rehydration. But you don't really have to IV hydrate a diarrhea unless they're unable, okay? And if we only gave liquids to a child with diarrhea, how's that stool going to firm up? So we have to reintroduce diet to these children. Now, constipation on children, many times it's due to something that's happening on with their life. And I've seen this over and over and over again. Usually constipation, very few are congenital from birth that you see these things, but usually you'll see them in those 3, 4-year-old children. And something's going on and they're trying to control it. I've seen them hold their stool for 10 days. And if you look at the x-ray of their abdomen, the whole descended, transverse, and ascending colon are full of stool. And it's because of stress. We just give an enema and we'll get rid of it. And then, of course, try to increase their bulk in their diet. We don't like to give chronic enemas to any child. It's a one-time thing. Now, constipation during newborn period. I've sort of mentioned it a little bit that constipation at newborn can be caused by certain things. So we will be starting to look for them. One is, of course, if there's some sort of physical reason, an atresia, which means there's no opening, or stenosis, very much a narrowing in the bowel, or it could be to Hirschsprung's, we're going to go into that, and hypothyroidism and cystic fibrosis. That's why if the child is not stooling in the first 36 hours, they'll be running these exams. They'll be doing the x-rays and they'll be doing tests for thyroid and for cystic fibrosis. So that usually will get them treated quickly because, especially with CF, they're not absorbing food, and hypothyroidism, they need that for cognition or they're not going to mature. They're not going to be aware. Now, sometimes constipation as they get older is due to diet. I know that formula-fed babies tend to have more full, harder stools than breastfed babies. Usually breastfed babies have lots of stools every day. Formula fed seem to have less. Now, what do we do for an infant with constipation? Well, sometimes the physician will say, well, give a little bit of apple juice or a little bit of prune juice, even if they're young, because they just want naturally something to help them stool. Very easy like that. Now, peptic ulcers. You think that children don't get peptic ulcers, but you do have these little young children that are in all of the stress that can. And we treat them just like adults. We're going to start out with giving them Zantac or Pepcid, one of those, Feminide. We're going to do that first and watching the diet. And then, putting on medications as they need. But usually they do well on that medication, and rarely have I seen it gone to the point of perforation on a peptic ulcer. Now, we can have some sort of hepatic disorder in children due to many different reasons. And we know that the one thing that we're always concerned about is making sure these children that their liver is not working well. And we know that the liver helps with fat digestion, right? So if we're not getting fats, almost like your celiac disease, we know that we have to change the diet. High protein, high carbohydrates, and low in fat, because they'll be having gas, abdominal pains, etc. So when you're choosing a diet for hepatitis, make sure you choose the one with the less fat in it, okay? Now, Hirschsprung's. This is what we call a congenital aganglionic megacolon. We'll say that 3 times fast. What does it mean? That means that descending colon does not have nerve endings in it. And it can't do peristalsis. It can't squeeze it out the anus and have a stool. Sometimes there is an obstruction in there, so you have to be concerned of intestinal obstructions. Also, sometimes you see that rectum, that little tiny little poke on the bottom, sometimes a little bit squeezes out and it looks like ribbon, like you would take icing and you squirt it out of those things onto a cake, that ribbon sort of look. That's sometimes what you see. And when we see that ribbon stool, we know that it's going to be Hirschsprung's disease. So once we say, could be, what do we do? Well, we're going to look at the child. Most of them are caught at birth. Some of them are later on, depending on the severity. But we're going to be doing a history, see what's going on, know about their stools, x-ray, barium enema, and we're going to do a rectal biopsy. And that biopsy is going to show no nerves. And what we have to do is that piece of intestines doesn't work. It's malfunctioning. We need to cut it out. And usually it's almost down to the rectum, to the anus. So we have to put in a colostomy. Most of the time, they are reanastomosed and put back together by the end of 1 year. But this is a two-part. They're going to end up with a colostomy to let that lower bowel rest, and then they'll reinsert it. Now, appendix. We know McBurney's point, right lower quadrant, pain, it's sudden, and we know that these children are so easy to see working in the ER. If they're walking, they're bent over, holding their right lower quadrant, and they're limping. And they're like, oh, and you know that that's an appendix. So first thing you're going to do is say, please don't let your child eat or drink anything from now on, right? That's number one. We'll do an ultrasound, we'll find out, and it's appendix. Now, if the pain stops, that appendix has burst. So it's a ruptured appendicitis now. So now you got a child who could have gone home the next day or later that night. It's going to be in the hospital for several days. What happens when that appendix bursts? You know, there's that space between the small and the large bowel, and all of those inner contents spew into the abdomen and causes peritonitis. Very bad infection of all the rest of the bowels are inflamed, they're reddened, they're angry, they're miserable. So number one, nothing to eat. You need to rest the entire intestines. Of course, IV fluids you need because you need fluids. IV antibiotics for that infection. You're going to be monitoring all the electrolytes, of course, and it hurts. All that irritation in that belly hurts. And these children need to get up out of bed. They need to ambulate, cough, deep breathe. They need to prevent all of those post-op infections. But the one thing that a peritonitis, ruptured appendix will have is an NG tube. It's a tube that goes from the nose into the stomach. And it's uncomfortable for the child. It doesn't hurt, it's uncomfortable. But what does it do? Well, the stomach continues to provide gastric acid, right? Gastric juices. And if it goes down into the intestines, it's going to make it angry because it's already angry, right? We have to rest it. So an NG tube is going to be there to keep that stomach empty and to let the intestines rest. Okay? Another thing. Remember, that appendix has spewed contents in the whole abdomen. So that abdomen is infected. When they close that wound, it's an infected area. It could dehisce. Checking that wound frequently, making sure it's not opening, very, very important because they will open many times. Now, intussusception, interesting diagnosis. The intestines come along, the large intestines, they're long, and all of a sudden, one piece just sucks up into the other like a telescope. And it is painful. These kids, when you see them, I usually see them at that 2-3-year-old age, and their legs are kicking, they're crying. You come up behind them, touch their belly, it's tense, and you cannot console these kids. It hurts when the intestines is inside, okay? One of the signs that you see with intestines is that sudden abdominal pain and current jelly stool. It's like this really thick, gooey jelly type stuff with a little bit of blood streaks in it. And you're like, oh, that's what it is. What do we do? Well, hopefully, if we can, we will get an ultrasound and show the intussusception. many times. All of a sudden, the kid's running around the room, the kid's fine because the intestines came out. Many times we send these kids home and just increase the fiber in their diet and they're okay. Sometimes we'll send them home and they come back. Usually it's spontaneous, it's all we do. Sometimes it will need an air enema to pop out that area, or it might need surgery to take out a piece of intestines. But usually we can check it like that. Just diet and just watch the children closely. Just increase that fiber. It does really work. Now, a diverticulum is this little piece like a skin tab that comes out of the small intestines, but inside that little tab is a really big blood vessel. And sometimes it rips. And what you see with this is rectal bleeding. And you really don't see the pain that you think you should. It's what they call painless rectal bleeding. And what they do is they'll go in, they'll figure it out, what's going on, and they'll go in and remove that little diverticulum because it's just going to continue to bleed and bleed and bleed and bleed. And these children do very well. IBS, mouth to anus, right? We have ulcerative colitis, segments, Crohn's, segments, but IBS is the whole intestines, right? How do we treat it? Well, some of the ulcerative colitis and Crohn's, you're going to need the steroids, but most of the time it's nutritional support, making sure that they have a diet that doesn't upset their stomachs, and that's the best thing we can do. Some of them end up on biologics, the ulcerative or Crohn's, but most of the time we try to just treat them by diet. Short bowel syndrome. Now, why would we have a short bowel? Well, my little Jessica was in a hospital, was having ND feeds, post-cardiac surgery, and her belly blew up, and we did ultrasound or an x-ray. We found out that she had necrotizing enterocolitis, which means a piece of her bowel burst, and it was spewing the bowel contents into, again, the peritoneum. So they had to go in and do surgery. They had to remove 58 centimeters of her small intestines, which means she has non-absorption now, right? That is short bowel syndrome. You don't have enough area to absorb the nutrients. It's a short bowel. What is the big thing with this? Is that these children, Jessica went home with a G-tube for feeds, went home with a Broviac, worried about infection like crazy with that, right? But hyperoral lipids at night, G-tube feeds during the day, and oral feedings. I actually had her, I believe she was 8 months old when this happened. And one of the last people I saw when I left the hospital, she was 18, skinny, but she was alive and she's a part of a triplet team. So it's good to see her. Hernias is when the intestines try to pop out from all different places, right? It could be the belly button, the inguinal area. It could be that the diaphragm doesn't completely close and it's up into the chest. That'll be your sickest newborn intensive care patient because there's no lungs to work on. How do we fit? What do we worry about these children? Just the normal sort of hernias is that belly button, if you can push in and out, and I think it's fun, push it in and out, it's soft and squishy, right? If it's soft and squishy, the hernia is great. Now, if you touch it, it's painful, you can't reduce it, that child is incarcerated or strangulated and it needs surgery now to correct it. Or that twisting of the intestines will die. Malrotation in volvus is another thing with your intestines. It's either that it's wrapped around, it's twisted upon itself, and it's decreased blood supply to an area. And sometimes because it's twisted and no flow, it'll perf again, causing the necrosis, peritonitis, etc. These are harder to diagnose. They're rarer to find though. How about an imperforated anus? This is an infant with no anus, and it does happen. Why do you think you do a rectal temp on newborns when they're born? You think it's to monitor their temperature, right? Get an accurate one. Well, it's also to make sure they have an anus. I never saw one in all of my career in the newborn intensive care, but they can happen, and there's a picture for you. Another thing that could go on is fistulas. It could be between the vagina and the bladder and the intestines, and really looking as you're cleaning these children, you might see stool coming out of a vagina. And that might be the hint to tell the doctor to go looking. And usually it's the nurse who finds that. Another thing that can happen on children is when they're, I believe I have it further on, the bladder is born on the outside of the body, where again, we have to monitor. I believe it's later. Hold on. Okay, vomiting. Now you have a child who's vomiting. What do we do for these children? I've already mentioned what we do with vomiting. Medical metabolic profile, start the IV, again, no dextrose, no potassium, keep them NPO and give them those antiemetics. Now, what happens if they take something? You know, the biggest thing I've seen children get into is their multivitamins. You know, those Flintstone chewables, I've seen them go through a whole jar of it. Now, actually, vitamins are benign because what you don't take in, you just excrete through your with your urine, okay? But there's other stuff that's very, very dangerous. So one of the things that we need to do is get them in to the ER. Hopefully poison control was already called, and then they're calling me by the time they even get there. I could be prepared as the triage nurse, but calling poison control, finding the most up-to-date treatment for these children when they get into things like iron in their pills or mom's cardiac medicine. I've seen them into rat poison, which means bleeding. Bleeding coagulopathies that get really prolonged. So there's different things and we need to be aware of it. Reflux. I mean, a lot of babies do have a lot of spit up, right? And this can go on into their later on in life. Now, GERD is when the food a little bit always comes up. And we know we've got to be concerned about infants not getting nutrition. So how do we treat medically a GERD on a small child before we get to the point of even needing surgical? Is we're going to be giving them, even the young 1-2 week old children that are spitting up like crazy, we'll put a little bit of rice cereal, usually like 5 mLs, a teaspoon in every ounce of formula. And what does that do? That rice cereal thickens the formula and it holds that food down, so they're not going to vomit, okay? They're not going to absorb the rice cereal. Their intestines don't work with it, but at least they got their food, right? Now, older children, what you're going to see is their, just think about it. Food comes up their esophagus, they aspirate, little aspirations. So they cough. It's going to hurt and they're going to feel that heartburn coming up. They're going to be put on every medication, your Pepcid, your PPIs, Maalox and Mylantas and everything that they can. And if it doesn't work, there is a surgical procedure that we usually use for putting in gastrostomy tubes. And it's called a Nissen fundoplication. And what that does, it pulls the upper part of the stomach up so that when they can't reflux. There's no physical way that food can come up, and they're protecting the lungs is what they're doing, especially on those older children. On those children with a gastrostomy tube, it prevents the food from coming up still, and they're not going to aspirate. Now, hypertrophic pyloric stenosis. This is the young baby, 3 weeks to 3 months old. Key time in life is usually 7 weeks, is what I've seen, where this child is vomiting. So you get an infant in, and the mother's complaining, my baby's vomiting. First question, does it drool or does it come out across the room? When it goes across the room, it's pyloric stenosis. And why does that happen? Well, the pyloric valve is way down at the end of the stomach before it enters the small intestines. It gets thickened, hypertrophic, and the milk can't get through it. So the belly fills up, fills up, fills up. They eat, and then I'm talking 10 feet away. Be careful. Aim that child towards the garbage can because it's going to go everywhere. And it is that forceful. It is that remarkable. So if I hear it's going like that, I'm going to take my hand and put it underneath the rib cage in this like center or a little bit to the right. And I'm going to feel like a little marble, a little olive. You can actually feel the hypertrophy of that pyloric sphincter. So what do? Well, we know if we feed this child, they're just going to vomit, right? So immediately I tell a parent, nothing more to eat. We will start an IV and keep them NPO. They don't need anything else but that until they get surgery. They go to surgery, they come back, and they will slowly introduce their foods again. And these kids do well with no problems in the future. Now, cleft lip. Cleft lip can be one side, two sides, and it could get the palate or not. I've seen it all different ways. The one thing that we need to be concerned about cleft palate is getting that lip first done. About 2 to 3 months will close that up so that they can put their mouth around something. Can you imagine how these kids eating? They can't suck. They can't get that suction, right? There's a hole, they can't. So that's number one, feeding. So get that done. And then the palate on top, they usually do that about 6 to 12 months. And why do they do it then? Well, the kid's not talking yet. And cleft palate, cleft lip can affect speech. So it's a big thing to get this done before they're a year old so they can speak properly. Now, that little bottle over there is a Haberman bottle. It was developed by a parent, and that upper little tube is soft. So when you turn the bottle over, that little area fills with milk. So as the kid is trying to suck, you squeeze a little bit, and they drink it. And so they're getting that sucking satisfaction. Remember, how do babies self-soothe? In the mouth, right? So they need to suck, they need to feed. They don't need an NG tube or anything. They can feed, they do well. Some mothers, and I, hands down, I admire them, try to continue to breastfeed and they squeeze their breasts as that child is trying to chomp down and get it. Again, remember, problems with feeding and getting them worn out can lead to not enough nutrition and again, growth failure. Another condition that can happen at birth is when the esophagus and the stomach, there's no connection, or there's a connection between the lungs, the trachea, and the esophagus. So think about it. Anything that goes down the mouth, it either gets, there's no place to go because the stomach's not there. It just comes back up. Or, excuse me, there's a connection between the lungs and the stomach. So they drink, it goes right into the lungs, and now they're aspirating. Okay. So how do we treat these children? Number one, nothing by mouth, nothing. These children usually come out, you'll see them coughing, spitting, foaming, a lot of mucus in their mouth. That's usually the first clue. And they're a little bit cyanotic because of the aspirating that they're doing. It's usually what you see. So these children, we need to have their head of their beds elevated, suction at the bedside to keep their oral airway clean. And because even though they're not eating, they are getting some of their mucus. It is having mini aspirations. These children will need IV antibiotics preoperatively to prevent those aspiration pneumonias. And the IV fluids will be, to give them the proper nutrition that they can. They will be doing surgery. They do fix it. These kids are normal, except these connections that were abnormal. So management, NPO, nothing by mouth, elevate the head of the bed, have suction at the bedside, IV fluids, and antibiotics. So a lot of good stuff, huh? You ready for a Cahoots? Let's see how much you remembered. Those of you who've never done a Cahoots, you go to kahoot.it and you're going to be putting in the game pin number 169-445. By the way, the reviews and the PowerPoint for your exam on week 10, I have okayed them today. My students have them already, and I know that the rest of you will be getting them pretty soon. Just did it about an hour ago, maybe 2 hours now. All right, let's get going. If you're not in yet, it's okay. Start when you can. The Kahoot code should be in the bottom corner as we go. Week 8, G-I-G-U, week 8, amazing. We're almost there, guys. A multi. All of the following are symptoms of dehydration in an infant except. Dehydration, whether adult, whether it's a child, they're all the same. Except for fontanelles, it's only infants, right? You're not going to have an increased urine output. Absolutely not. So it's pale, dry skin, prolonged capillary refill. You're going to be weak, lethargic, change in mentation. You'll see elevated heart rate, decreased blood pressure, decreased urine output. So many things that you can look at. What is a priority treatment for a child with dehydration due to profuse vomiting? What do we do to rehydrate a child vomiting? So we're not going to do anything but give them IV fluids and antiemetic. If you give a child who's profusely vomiting, you give them something, they're continuing to vomit. So we don't want to do that. Rest the stomach. And then slowly we'll reintroduce when we can. What is a treatment for an infant with diarrhea lasting for 4 days? This has nothing to do with the kids vomiting, it's unable to drink. And we know that children with diarrhea, we're going to be giving them by mouth, okay? Unless their condition states that they are unable to drink. We can very simply start Pedialyte, Gatorade, Powerade, one of those. What acid-base imbalance may you see with a child who's having profuse diarrhea? Remember, diarrhea is where all of the digestive enzymes come out, and those digestive enzymes are alkaline. So you are spitting out alkaline. What's left? What is left is acidosis. So it's metabolic acidosis. What would you see with vomiting? You're spitting up all the gastric acid, right? So you're getting rid of acid. What's left? Alkaline, right? So it's metabolic alkalosis. Remember those two? You're just going to see those whether in this class or Med-Surg 2. A multi. If an infant has not passed the meconium stool within 24 to 36 hours, what would you assess for? So electrolytes really have nothing to do with it. We're going to look out for these conditions: hypothyroidism, cystic fibrosis, and Hirschsprung's. Because remember, it is all about nutrition. They're not getting the proper nutrition. We need to maintain that, or they're cognitively, they're not going to be there. and they're not going to grow the way they should. Deficiency of vitamin D causes. What is D used for? Do you know? You look at vitamin D, you think calcium, vitamin D, and they work together. And when you think of that, you think of bones, right? So it's rickets. Jaundice has nothing to do with deficiency of vitamin D. It has to do something to do with your whether hepatitis or whether an obstruction in the bile duct, okay? So scurvy is vitamin C. Multi-select. What treatment can the nurse anticipate to drink if a child is unable to drink or eat anything with profuse vomiting and diarrhea? So what are you going to do? Kid can't drink, can't eat, vomiting, diarrhea. What do you need to do? Remember, dehydration is very dangerous in children. We'll be monitoring their basic metabolic profile to see their hydration status, and we'll be giving IV fluids. Very important. They're unable to drink, they're not going to take anything by mouth, okay? A multi. What nursing management would you anticipate for a child with a ruptured appendix postoperatively? Just think about the appendix. It has bust open and spewed contents within that abdominal cavity, right? So then think, what management do I need to do for that? I am going to do everything, but you don't do complete bed rest. Remember, this is a post-op patient. We're going to administer pain medicine, getting them up out of bed, cough, deep breathe, ambulate. We need to get those intestines moving again, and that is done with getting them ambulating, okay? So no bed rest, but the NG suction, keep it empty, make sure that the wound doesn't dehisce, and of course, this is a peritonitis. IV antibiotics. Passage of urine, usually at night in children who should have voluntary bladder control. What's the other name for it? I briefly mentioned it when I talked about urinary tract infection. They tend to have enuresis, or they tend to have accidents at night when they're already potty trained, right? Now, epispadias and hypospadias. This is in a male infant born with it, congenital. Epispadias is when the whole of the urethra doesn't come to the end of the penis. It's on top somewhere on top. Hypospadias is when it's underneath somewhere. And the one thing about these two conditions is we can put that hole back on the end. And usually that's done within the first year of life. But we need the foreskin. Now, think about when would that be a problem, saving the foreskin? What about the Jewish faith, right? They like to do a brisk. And because of it, they can't. They need that skin for the closure. You're going to see on the study guide I sent you on epispadias, hypospadias, a great surgical picture. You can see how they splay the penis in half, literally open it up. And then they put a catheter down in there and close it up with the foreskin. And then we leave a catheter in there for 7 to 10 days. We don't do anything with that catheter. We don't twist it, we don't turn it, we don't do nothing with it. Just make sure it's inside the diaper, and that keeps that lumen open. So it's quite an intense surgery. A multi. What is Hirschsprung's disease? So Hirschsprung's is that big bulging lower descending colon. It could cause bowel obstructions. It's also called aganglionic megacolon. Remember, there's no nerves, which is aganglionic, okay? So if there's no way for peristalsis, it doesn't work, we get rid of it. How do we treat it? Well, we find out it's there, we do the biopsy, and we put a colostomy on that child, and up to about a year, and then they'll hopefully reconnect it back up. When teaching parents about Hirschsprung's disease, the nurse would include what? Remember, one of the signs of Hirschsprung's is those little ribbon stools. It squeezes out that little end of that intestine. I look at like icing on a cake, the little thing that you squirt and put it there. But it does, it causes a bowel obstruction. You have to monitor those children, and it is a 2-stage surgery. We never treat anything with children with laxatives and enemas. We will do something more natural. If they're constipated, one time we'll give an enema to get it going, but it is not something we do consistently. What types of stool would an infant with Hirschsprung's disease have? Again, those are the ribbon ones. Very good. Which is a condition that occurs mainly in children when the intestines telescope into itself. It just sucks in. It is called intussusception. Remember, many a times it'll pop out by itself. We'll send them home many times when they're doing well, increase the fiber, but sometimes we do have to do surgery on them to get rid of that area, especially if it's sat there too long. GERD, gastroesophageal reflux disease. What's that? And that's when the stomach, the contents goes back up into the esophagus and it hurts. You know, children, infants, you'll be feeding them or you'll be holding them, and all of a sudden you'll see them arch back and you're like, this kid is refluxing. And sometimes that's how we get the treatment, just because maybe a little bit of spit up, but you could see them arch their back and you know it hurts. Remember, older children, they'll aspirate on it, okay? And have that burning heartburn with it in older children. That's what we would see. Little children, oh, that arch back, I can still see it. IBS, inflammatory bowel disease, involves what? Any part of the intestines, it's mouth to anus. Any part, anywhere could be inflamed. Non-discriminatory, right? What would the nurse be looking for when a patient has Meckel diverticulum? Remember this little outpatching little tab in the small intestines. And surgery is done to correct it. There might be a little bit of abdominal tenderness, but usually it's absolutely painless. You don't see it. No, you don't see a distension, maybe slight tenderness, and it's basically painless rectal bleeding. A 6-year-old child goes to the ER due to abdominal pain, fever, vomiting for the last day. What assessment is priority? What do you need to know? And you have to know how to treat this kid. You know, if the kid goes to the ER, they go through triage, and the triage nurse needs to know, where do I place this child? Are they urgent or less urgent, right? So what question am I going to ask? Tell me where it's at. Is it right lower quadrant? Now you're an appendix. We need to get you to surgery and ultrasound as soon as we can so it doesn't burst, right? So that is the most important. Is it in the belly button? Okay, that's more like, you know, vomiting, maybe, you know, heartburn type thing. But right lower quadrant, something you need to worry about. What would the nurse expect to see in an infant with biliary atresia? So the bile duct is non-existent. So bile is not going into the common duct, not going into the small intestines. Bile is not excreted, can't. Well, we know the kid's going to turn yellow, absolutely, and go jaundice. But because the bile is not going into the intestines, that colors the stool. So there'll be clay-colored stools. Also, what does bile do? It digests fat. Even formulas, even breast milk have fat in them. What does fat, it doesn't get used up or digested properly, what does it do to the child? It causes gas, abdominal distension. So that's why clay-colored stools and abdominal distension. Those frothy things are from your celiac disease. What structure of the mouth can be impacted by a cleft lip and a palate? It's everything. You know, I've seen some extremely good closures on that. It's extremely plastic closure. They take really good attention to it. Cleft lip repair is done when? Remember that baby has to put its mouth around some nipple of some sort. And that's the way the Haberman bottle looks like when it's used. And that one finger is sort of squeezing it as the baby's sucking. So we do the lip first between 2 to 3 months. And then they put that little logum bar there. It's like a little metal bar. So when they're smushing their face in the bed, they're not going to rip it open. You got to keep that nice. When does a cleft palate repair typically occur? Remember, the palate has a lot to do with speech, right? So when do we want to get it done by? And that's 6 to 12 months. Very good. So always remember that. That lip, the palate, we got to make them self-soothe, and then we need to keep their speech. Esophageal atresia. Remember, A is without. So we have an esophagus and it doesn't connect to anything. So it's a lack of opening between the esophagus and the stomach. Now, is the stomach there? Yes. Is the esophagus there? Yes, but there's no connection. What are the classic signs of esophageal atresia and tracheoesophageal fistula? What are you going to see at birth on these children? No connection to the stomach, and then a connection between the trachea and the esophagus, a connection called a fistula, an abnormal opening. These children are going to be gagging and choking because if they swallow anything, it goes down their esophagus and directly into their lungs through that fistula. Or it's going to go down the esophagus, come back up and into to the lungs. Current jelly stools are intussusception, okay? Olive-shaped mass, pyloric stenosis. These are things you need to remember. A multi. Neonate suspected tracheoesophageal fistula. Nursing care should include what? So I want the head of the bed elevated and nothing by mouth. And because they have those little mini aspirations, we want to give IV fluids because they're NPO, but antibiotic for those prophylactic for those aspirations, so there's no pneumonia. Now, the head of the bed for feedings, well, this kid's not going to be eating nothing, because it'll go directly into the lungs, okay? NPO, IV fluids, antibiotics only. A 5-year-old child is complaining of epigastric pain and a persistent cough. What do you suspect? What is that? And that's a GERD, esophageal reflux disease. That cough is that mini aspirations, the pain is in the esophagus, is burning and it hurts, okay? And remember, we could treat it medically, but the most drastic would be a Nissen fundoplication, where we do surgery and take the stomach and flap it in a way that food can't go back up there. What is ranitidine used for in a child with peptic ulcer disease? Whether it's the Zantac or the Pepcid, famotidine. And we know it's all about reducing the production. It doesn't neutralize it. It reduces the stomach's ability to produce gastric acid. And that decreases the acid and decreases and helps soothe the stomach. Signs and symptom of hypertrophic pyloric stenosis. Remember, it's that little valve that connects the stomach to the small intestines, and it's thickened, hypertrophic, it's muscular. Liquid can't go down there. And if you take your hand and you put it up there, you're going to feel the olive. And I felt it many, many times. And olive or a marble, whatever you want to call it, you do feel it. It's very clear. Signs and symptoms of hypertrophic pyloric stenosis. Now, these kids are hungry. They are eating, vomiting, and then they are crying. They want more, more, more. It's not a poor appetite. It's because they're not digesting it that they want more and more and more. It has nothing to do with their appetite. It is projectile vomiting. And these kids, they'll eat, they'll vomit, and they want to be fed right after. So it's not poor appetite at all. Only that vomiting. Preoperative treatment of pyloric stenosis includes what? This is a kid, you give him food, he's going to vomit. So what do you do? So this child, you're going to make NPO. Very important. They do not need to be eating and vomiting and eating and vomiting. And you want to rest that stomach so they can do the surgery. It's like 2 hours before surgery, an infant needs to be NPO. That's it. And IV fluids. They don't need antibiotics. It's just fluids and NPO. And they do well. We introduce food the next day and they go home. What does the celiac disease affect? and it's the small intestines. And I asked that question because students always get it confused. Celiac disease has to do with food and digestion of food. Where does digestion of food occur? In the small intestines, with all the enzymes that go in there to try to help make it into a workable form for the body, right? Large intestines has nothing to do with it. It's all small intestines. If you have celiac disease, what should you eliminate from your diet? Wheat, rye, barley, and oats. Okay. They can have vegetables, they can have dairy, they can have chocolate. None of that's a problem. It is everything those flours. Okay. So you have to be careful with, breads and cakes and cookies and cereals and all that good stuff. A multi. Vitamins that children with celiac disease are prone to lose are, remember about steatorrhea and that malodorous stools. Why are they malodorous? Because of what? I remember it has a lot to do with fat-soluble vitamins. And which ones are fat-soluble? A, D, and K. Vitamin C is water-soluble. So we're always concerned about fat and nutrition on these children. What foods would you select for a child with celiac disease? We're gonna do something easy. Bacon, banana, eggs, omelet, glass of milk, ice cream, all that good stuff. Now, fish sticks have a breading. Macaroni is a, sort of noodle, which has to do with a type of flour. French toast, again, it's a bread. And then, of course, garlic bread. So the one that had no bread in it, I mean, chicken nuggets have, breading on it. So the only one is that first one. Phimosis, something I didn't discuss, but I would tell you now. So one of the things I told you about is urinary tract infections in males. And one of the things that I said is that mothers have a hard time sometimes pulling back the foreskin of their male infants. Sometimes what happens is that foreskin is so tight, you can't pull it back. Now, my grandson, poor guy, I'm talking about him again. He was, 1 week old, and my daughter said, I can't pull it back. Can you help me? And, I have a little bit more experience. And I tried, did all my tricks. I'm talking about was the tightest one I've seen. He had to be circumcised because we couldn't clean it. But it is tight and you can't pull it. And sometimes you pull it back, it gets stuck. But that is not called phimosis. It is just that it's tight.
I thought you weren't supposed to pull it back until a certain age.
No, you're supposed to be pulling it back to keep it clean. It should be able to be pulled back from birth, actually. That's a misnomer. But thank you for that question. And you're telling some mothers there about that. What's a hydrocele? I mean, this can happen at any age. And it's some sort of inflammation, some sort of infection. And usually it's treated by a shot of Rocephin, believe it or not, ceftriaxone. But it's somehow, some way, there's a little bit of fluid that goes around the testes, and it causes an irritation and the pain. And or they have a period of incontinence where they haven't been before. And what they do is just do a urine on them and give them a dose of an antibiotic, and they usually do well. What is cryptorchidism? We see this in your younger infant boys. I mean, what does the pediatrician do on the first visit of a male infant? Well, we'll check for hip dysplasias. We'll listen to everything, but he always checks to see if both of the testes have descended, right? Sometimes one or both of them don't come down. We know if we leave them up inside, it's too hot for them and they won't function. So after a certain time, sometimes have to surgically bring them down. Now, one of the things about this is males, if it's cold, their testicles suck up, okay? So do their testicles because it's protecting them. Now, when it's warm, they tend to sag a little bit more, right? So how do you think we're going to examine this little child? In a warmer room, right? Because we want it to have it down as far as it possibly could be. So that would be how we examine them. So you suspect an infant with a cryptorchidism, how would you examine them? And again, this kid you're going to put in a warm room. We want those testicles to sag as much as they can. We want to get a good enough feel of them. Another thing we're going to ask, if we find that one testicle isn't down, we're going to ask, have you ever felt that testicle down? It's a very important question to ask also. A hypospadias. And we have an epispadias and a hypospadias. It doesn't come out the end, the urethra on a male, right? So is it dorsal or is it ventral? And it's on the ventral side of the penis, okay? Again, I told you how to correct it. It's surgical. We need the foreskin, and we're going to put a catheter in there. And that catheter is going to sit. They actually use, if you've ever done a female straight calf, that little plastic tube-like thing, they usually put one of those in there because it's just big enough to hold that opening up the way they want. And then after 7 to 10 days, the urologist will remove it. A multi. How is a hypospadias corrected? The foreskin is used, a stent is placed, and once you see those pictures on the study guide, you'll understand it is general anesthesia. They cut the penis down, lay it open, okay? That's how severe this is, so it's general anesthesia. What is bladder exstrophy? I briefly mentioned this, but didn't go into detail earlier. I thought I had another slide on it. I know it's on the study guide. I thought it was in this PowerPoint. I mean, we've talked about gastroschisis, where the stomach is born on the outside. Well, bladder is born on the outside. And it's because it didn't close all the way. Now, the bladder's out there, which is pretty cool, because it's intact. We just got to get enough room to stick it back in there, okay? Now, we need to keep it sterile and usually moist. So I have some saline at the bedside, sterile saline, sterile dressing. We keep it moist, and when we make enough room, we'll put it back in there, okay? Now, we still have them urinating the same way. The bladder's just in a different place. The urethra still goes to the outside. So it doesn't affect any of that. You just got to get it pushed back in there and prevent infection. What is the priority nursing care for an infant with bladder exstrophy? So it's all about the tissue integrity. That's why anything that's born on the outside, your gastroschisis, your myelomeningocele, your bladder exstrophy, have normal saline, sterile normal saline with sterile dressing, and they'll keep it moist and they'll keep it sterile. So until we can get it back inside, it's not going to lose any of the tissue integrity. Very good. What are the clinical manifestations of nephrotic syndrome? So remember, this not kidney failure. They're urinating normally, right? The problem with nephrotic syndrome, they don't like protein. And they say, I don't like you, so goodbye. And they urinate, urinate, and urinate protein. With that, you're going to have low protein in the blood, low serum albumin, and you're also going to have some peripheral edema. Because remember, the inside of the tissue becomes where it tries to make an isotonic solution. So it pushes fluid out interstitially, okay? So you do swell everywhere, like your mouth, your tongue, your eyes, you'll see it everywhere. Treatment, intake, output, daily weights, and we do steroids for this. Children with nephrotic syndrome are often given what medications for fluid overload? Remember, you have all this interstitial fluid. We need to pull it back into the vascular and we need to get rid of it. How do we do it? Well, I'll ask you, what is albumin? Isn't that protein? So let's give them some protein and follow it by some furosemide, some Lasix. And that's how we can get rid of some of the fluid. And we know how we're progressing by what? Intake, output, and daily weights. What is used to treat nephrotic syndrome in children? And it's prednisone. No. Is it observation of vital signs, fluid balance only? No. It is both vital signs, fluid balance, and prednisone daily weights, right? A child is admitted with acute glomerulonephritis. What recent illness could validate this finding? Jose, you'll remember this forever. And that's the pharyngitis, which could have been strep. Very good. How do we treat it? Antibiotics. Hopefully it will turn around. What is a priority nursing care of a child with nephrotic syndrome? I think I've said it at least 10 times today. Monitor daily weights and intake and output. Very good. Why is erythropoietin used in chronic kidney failure? You know, we use erythropoietin in many different things. We use it in cancer, you know, with chemotherapy. We use it in kidney failure. And it's because we want to have the body produce as much as it can, you know, and decreasing a blood transfusion is what we want to do. So erythropoietin is used for your red blood cells. A multi. Children with chronic kidney disease can have renal osteodystrophy. What can this do to a child? What does osteo mean? It means bone. Dystrophy is an abnormality. So what can that do? Thinking of what the word is saying. And it could be high parathyroid, which is high calcium. you're going to see skeletal abnormalities and growth retardation. It could be crooked bones, short bones, and we know that calcium is also going to be crazy on these. Because remember, parathyroid is all about calcium regulation. A diagnostic finding of acute glomerulonephritis may be. Now I'm asking this in a different way to see if you can put them both together. And it's a positive ASO titer. Look at the word, anti-streptolicin. Now, sometimes the kid is a poor historian or the parent don't know. So we'll draw lab works and we'll do an ASO titer. The ASO titer comes back positive. We know the cause of acute glomerulonephritis, and that's why we use it. I hope that will help you. What complication of peritoneal dialysis is most important? Remember, you have one abdomen. And if we are not using absolute strict sterile technique, that abdomen, that peritoneum can become infected. So the biggest, their priority to prevent is abdominal peritonitis. What clinical assessment is most important to report with a child diagnosed with an acute kidney trauma? I had a kid who was playing hide and seek or something, and he was running the backyard, was running half backwards, and his back ran into a hitch from a trailer, and his whole back was bruised. I mean, huge, right over the kidney area. And what was I most concerned about? I wanted to know what his potassium level was, and it was actually 7.5, I believe. He had a fractured kidney from himself running into a trailer hitch. So that would be the one thing that we would look at. Very good. Kidney potassium, yes. A multi. What should the nurse anticipate for a child who just had a renal biopsy? So we're not getting this child out of bed at all. So no ambulation, INO, monitor dressing, bed rest, look for abdominal distension. We're gonna make sure that they're urinating and that they're not oozing anything.
Why are they on bed rest? I missed that earlier.
Okay, 1 second, I'll tell you. What would you do if fluid draining from peritoneal dialysis has changed color and is now cloudy? I'll tell you in a second. Well, if it's changed color, something's wrong, probably an infection. And remember, we've got to save that peritoneum. So tell the provider, and that provider is going to order some antibiotics. Now, what was your question again exactly?
Why do we keep them on bed rest?
Okay, well, just think about a renal biopsy. You stick a needle through their back into their kidneys. Just like a cardiac cath, we have stuck it down into these big vessels, which
That
the
makes
clot could pop open, and now you have urine spewing or blood spewing, and it could go outside and fill up the abdomen too. So you have to be careful to keep that from opening up and allowing those complications. Okay? Last question. What would the nurse provide to an infant that cannot eat normally? What do you know about infants? They can't eat. What are you going to do for them? I mean, we need to provide proper growth and development, right? And that's all about that non-nutritive sucking pacifier. It's that self-soother, and it's what infants do need. So that's what we will provide. If they can't eat, there's a reason for it. We're not going to do anything, put anything in their mouth, because it could harm them. And here we go. Ashley, number 3. Good job, Ash. Number 2, a urinary tract. Look at that. Complete with kidneys. Number 1, APA. You guys are silly. Jess and Sarah, good job, guys. So actually, I got through it all. I didn't take all night long. So any questions, any comments, concerns that you need, I'm here to help you. And if that's okay, we've had a great class. Thank you. I will be giving these to your other professor, this recording, so that you will have it. Also know that if you don't get it quickly, you can get me on Professor Bogart Pediatric Nursing on YouTube. So just go to YouTube, put Professor Bogart in, and you get me. And you will get week 8 recording, okay? And it will be there. Also, did you all get the matching GIGU form? Okay.
Yes.
I will be posting the answers to that. It covers every concept you need to know. And I did it initially as a quiz when I was on ground, but I liked it so much, I thought it was a great tool for y'all to check yourself and to study from. So that's why it's there. So you guys have a great day. Thank you so much.
Professor.
Before
Thank
we
you.
You're very welcome.